And it's been known that environmental factors play a role in cancer development for more than 2 centuries. And in the 1700s, this Dr. Pott described scrotal tumors or cancers in young chimney sweeps. And that led to early public health legislation regarding disease prevention. Next. And the relative contributions of genetic and non-genetic factors to the development of cancer has been debated for decades. And there's this back and forth, and really it's not either or. So the relative contributions are expressed in terms of the population attributable risk, the percentage of a disease incidence that would be eliminated if a given risk factor were removed. Next. And the epidemiologists have long known that for most cancers, environmental factors have a very high attributable risk, as high as 85 to 95% in Western populations, even when the specific carcinogenic agents or agents in a particular exposure are not absolutely clear. Next. And the sparseness of the relevant research to date has led people to estimate only 6% attributable risk of cancer from environment and occupational chemical exposures. And the panel believes that that understates the true hazard and represents a missed opportunity for risk reduction. And they argued for expanded research on the relationship between cancer and environmental materials such as hormonally active products like bisphenol A and the new nanomaterials that we're manufacturing. Next. Of the 80,000 chemicals and products on the U.S. market, many of which are imported, only 200 have been adequately tested for carcinogenicity. The current regulatory approach calls for safety testing only when evidence of possible danger arises. So you've got to sort of bang on the doors of the regulatory agency with your concerns forever, and then when they do get around to it, you know, they can be quite forceful and effective, but this has been almost a design by purpose because it's in favor of industry and manufacturing, and it relieves them of any obligation to prove in advance that the materials that they use are safe. And since most cancers have a long latency, they're long latency diseases, waiting for population-based evidence of a problem allows avoidable cancer epidemics to occur. This is from the president's panel. He's a very conservative scientist. Next. So this is just a couple examples of what's out there. There's a lot, and there's actually a lot of data that doesn't conclusively support a direct relationship. And in part, I think that's because of the hereditable factor. So I think a given toxic product can be a greater problem for an individual with a hereditable predisposition. But when you do large populations, maybe only 10% of that population will have the hereditable predisposition. And so the effect of the toxin in the broader population isn't quite so evident. This is also true for testing new chemotherapy and biologic agents for cancer. And they're finally coming around to realizing that when you're doing a clinical trial, if you identify the people who have the genetic predispositions to benefit, either the genetic aspects of the tumor itself or the individual who has the cancer, the ability of a trial to demonstrate the value of a chemotherapeutic or biologic agent is improved, and increase the likelihood it'll be approved by the FDA under maybe more limited indications based on markers that they can now get. But this is a big advance that's happening all around us. So this looked at blood levels of organochlorine residues and risk of breast cancer. It's from Mount Sinai School of Medicine, and it was published in next, I think it'll. Well, I don't have I don't think I have the journal. It showed that the organochlorines such as DDT and PCBs, which have been used extensively as insecticides and as fluid insulators of electrical components respectively, are known to be persistent contaminants in the environment. Next. So they did a blinded study, was designed to determine whether exposure to PCBs and to DE, which is a byproduct of DDT, is associated with increased breast cancer risk in women. And the sera was from stored blood specimens of 14,000 people enrolled between 1985 and 1991 in New York City University's Women's Health Study. DDE and PCBs were measured by gas chromatography in the sera of 58 women with a diagnosis of breast cancer 1 to 6 months after they entered the cohort, and in 171 matched control subject from the same study population who did not develop cancer. Next. The mean levels of DDE and PCBs were higher for breast cancer cases than for controls, but the paired differences were only significant for DDE. Next. After they adjusted for other risk factors like first-degree family history of breast cancer, lifetime lactation, age of first full-time pregnancy, they were able to show a 4-fold increase in relative risk of breast cancer for an elevation of serum DDE concentration from 2.0 nanograms to 19.1 nanograms. So there was a continuum related to the dose in the body. Next. The PCBs weren't as evident, and it was characterized as non-significant. Next. So in this population of New York City women, breast cancer was strongly associated with DDE in serum, but not with PCBs, and suggests that environmental chemical contamination with these residues may be an important etiologic factor in breast cancer. And many of us at our age had more significant exposure to DDT because it was on the market when we were kids. And I know the story of some who ran behind the chemical trucks to be in a cloud when it was spraying on the streets. Next. So when you add that to possibly DES exposure in utero, there's this cumulative effect that then may help us understand risk. So this just looks at another one, which is cadmium exposure in breast cancer. Now, for years we've known that cadmium is a risk factor, is found in higher quantities in breast tissue of women with cancer. Next. It's a highly persistent heavy metal, has been characterized as a probable human carcinogen, and the primary exposures were from food and tobacco smoke. Next. This looked at a population-based case control study of 246 women aged 20 to 69 with breast cancer and 254 age-matched control subjects. The women in the highest quartile of creatinine-adjusted cadmium had twice the breast cancer risk of those in the lowest quartile. And that's after, again, adjustment for established risk factors. And there was a statistically significant increase in risk with increasing cadmium levels. Next. So we know that its presence is significant, but only now, and this is a study that I think came out of this year, is within this year, it looked at what the mechanism might be. So cadmium promotes breast cancer cell proliferation by promoting the potentiation, by potentiating the interaction between the estrogen receptor and c-Jun, which is a protein that's a transcription factor. And so the estrogen receptor is activated, and it activates then a transcription factor that increases, that ultimately leads to increased breast cell replication. Next. And so we know that cadmium is an endocrine disruptor, and it stimulates estrogen receptor activity and promotes uterine and mammary gland growth in animals. And it's been associated with the development of breast cancer. Next. They found that the estrogen receptor is required for cadmium-induced cell growth and modulation of gene expression. They determined that the estrogen receptor translocates to the nucleus. So if it's on the cell wall, it gets moved into against the nucleus with cadmium exposure and potentiates, again, the transcription factor activity that ultimately leads to the production of the proteins that create cell replication.